In this session, I will discuss a case of IVUS guided multivessel Rotastenting with low volume contrast in a renal failure elderly patient. So this patient is a 75-year-old male with ischemic heart disease and recurrent unstable anginas with normal sinus rhythm and good LVRV function. His eGFR was 34 ml and he is type 2 diabetic as well as hypertensive. So angiogram showed RCA significant, almost tight lesion in the mid RCA, and distal vessel is fine. But if you observe, there is a lot of calcium in RCA territory. It's almost like calcium. So, and left system also showed significant disease in LCX as well as LAD. So two vessel disease, and again in LAD it's a long lesion, and there is a bunch of calcium sitting along the lesion in LAD, but LCX there is not much of calcium in this lesion, so fluoroscopically. So essentially it is a triple vessel disease with calcified vessels and syntax score of 26. So obviously anything beyond 22, syntax 1 says CABG is superior to PCI in terms of future revascularizations. But when we took syntax 2, taking his surgical risk into consideration, so it showed almost similar 4-year mortality with PCI and CABG. So we offered both options to the patient, but patient wanted PCI. So what are the issues with PCI in this case? The most important issue is the calcium. So calcium in LAD and RCA, not much of calcium in LCX, which may need a atherectomy. So if at all we have to do a atherectomy in LAD and RCA, so mainly in LAD, there's a long disease and the vessel is looking like something around 2.5 or 7.5 in angiography. So we may have to take an ablation up to 1.25 or 1.5, anything. But because there is a diffuse disease, we thought of ablating with 1.25 first to prevent slow flow in these kind of situations. But if imaging shows a need for further ablation, then I'll go for 1.5 ablation. And second challenge is eGFR. So we can't give much contrast, so we have to do angioplasty with low contrast volume. So as his creatinine was 1.7 and weight is around 65 kgs, probably we cannot use more than 70 to 90 ml of contrast for this patient. So with this background we started procedure, and without giving any angiographic shots, so I went ahead with wiring of LAD and 1.25 balloon dilatation. And after 1.25 dilatation, I tried navigating IVUS into LAD, but I couldn't cross lesion. So then I thought I would go ahead with rotablation. So we went ahead with rotablation with 1.25 bar as discussed, and then I could navigate my IVUS catheter down. So IVUS showed, So in this, when you do rotablation, so always first few ablations, you have to spend time on ablating lesion. So just go and touch the lesion. This is the site of lesion. Touch the lesion and come back. So with a progressive movement forward, so we can ablate lesion effectively. So, and after some time, you can cross lesion without any difficulty, and this is the final run, so which shows not much of resistance. After 1.25 bar, I was shocked. Still there is a circumferential calcium in LAD, but if you observe, the site of circumferential calcium is proximal to the tightest lesion. It's not at the site of lesion. And there is another calcium with circumferential fibrosis point here as well as here. So yeah, you can see this is the IVUS after 1.25 bar ablation. So you can see, there is a calcium, so almost circumferential calcium here. So which says, you need further ablation. So we decided to go ahead with 1.5 bar. So you can see the vessel here is almost around 1.75. So 1.75. So I thought of going ahead with 1.5 bar as 1.75 was not available. So yeah, we did 1.7 bar ablation. So and after that again I repeated IVUS. So yeah, you can see the same technique which we have to follow. So initially you bar only the lesion and just touch the lesion and come back. Never try to cross the lesion at the first go. And then slowly, once the lesion is ablated, you can cross the lesion with the bar, and then you can do complete ablation of entire lesion. So yeah, and this is a post 1.5 Rota bar IVUS, post 1.5 barring IVUS, which showed again calcium, circumferential calcium proximal to the lesion site. So yeah, I mean the vessel was almost 1.75 to 2, so that's why 1.5 bar didn't work out. Probably 1.75 must have been done a good job in this case, but as it was not available, so I couldn't do it. So at this juncture, so whether to go ahead with stenting directly or so there is a need to modify this block further. So I would always modify this site of block further, otherwise your stent won't expand properly. So yeah, so these are the findings which you can make out only in IVUS. It's very difficult to understand how your calcium is ablated fluoroscopically. So then I took a cutting balloon because there is a severe fibrosis here. So yeah, I took 2.5 ton FLEXTOME and did a cutting there, and with the same balloon I tried ablating here, but there is a kind of dog boning at the proximal calcium site. With the repeated dilatation, FLEXTOME got ruptured, and you can see the contrast seeping down into the LAD. So then I went ahead with stenting. So the distal stent, as I was showed, this distal reference was 2.75 and the proximal reference was 3.5 to 4. I decided to use a two-stent strategy with a distal stent of 2.75 32 mm, 2.5 32 mm, and the proximal stent of around I think 3.5 24. Yeah, so after distal stent expansion, so I retried to modify the proximal lesion. You can see when I dilated with 3.3 by 15 NC, there is a kind of dog boning here. So then I took a 3 by 8 NC, and also I did a FLEXTOME here. So then there is a complete expansion of balloon, which you can see here. So, and you can see this is a post FLEXTOME images. So before there was a circumferential calcium here, now you can see there is a cut here with a clear ultrasound rays penetration, and also there is another cut here with a clear visibility of tissue underneath. So we can see here, so, and you can also see here in the distal calcium and fibrous ring, So there is one cut here with the penetration, and there is another cut here and also another cut here. So there were almost 2 to 3 disruptions in the circumferential calcium, so which ensures your stent expansion at the first go. You can see here, so there is clear cut in the calcium, and also you can see here, yeah, this is a most important site of calcium. You can see cut here as well as here. So there is a significant block, modification with good ruptures within the calcium. So then I went ahead with 3x32 Promus stent. You can see how well the stent is expanded. This is a site where there was dog boning with the balloons and rupture of cutting balloon, but you can see how well it is expanded now. So always we have to see the stent expansion in 2 orthogonal views, then only you will understand whether it is fully expanded or not. See, you can see there is a very well expansion of the stent. So, and I post-dilated distal stent with the 2.5 as well as 2.75 NC, then the proximal and stent and overlapping with 3x15 and 3.5x15, and you can see these are the final diameters or final areas which I got after post-dilatation. So the distal difference was around 3.5, and the distal stent was almost 3.7 to 3.9 mm square, and the proximal stent almost 6 to 8 mm square. So there was a good stent expansion throughout, and if you see the expansion of the stent at the site of the calcium, so it's almost here it's 5.8 or 5.9 mm square, and in the site of distal calcium or calciofibrous ring, it's almost like 5.5 mm square. So there is a good expansion of stent in 2 sites of circumferential calcium. So then we did LCX. It was a bit straightforward. There is no calcium in LCX, so we directly went ahead with balloon dilatation. And initially I was showed it's a 2 mm size vessel. The distal difference was 2 mm and proximal difference was almost 2.75. So we decided to go ahead with 2.25 stent and with the proximal post dilatation with 2.75. So yeah, I did a pre-dilatation with 2 balloon and then 2.25 by 28 mm stent, and post-dilated with 2.25 distally and 2.75 proximally, and these were the final areas. We got a good post-stent areas. Next we came to right coronary artery. So right coronary artery, you can see there is a tight lesion and calcified lesions. I tried negotiating IVUS, it didn't go, so then I dilated with 1.25 pre-balloon. Then I retried sending IVUS catheter, but it didn't go, so then I exchanged my Workhart's wire with Rota wire with balloon trapping, and then we did a 1.25 Rota ablation, and after that I repeated IVUS. You can see the movements of